Welcome to the deep dive.
Good to be here.
So you've sent us just a massive stack of sources. We're talking articles, studies, a lot of new regulatory updates.
It's a huge stack, yeah.
And it all paints this really vivid picture of what it actually means to be a physician right now in 2025 and heading into 2026.
Exactly. Our mission today is to synthesize all of it. We've got the latest on burnout, the biological cost of shift work, which is fascinating.
And then the really practical stuff, right? Compensation, job markets, and these huge changes coming to student loans and malpractice.
All of it.
Okay, so let's unpack this. I think the core question, the big one, is pretty simple, but really heavy. How does the intense, relentless demand of modern medicine really impact a physician's body, their mind, and their financial future?
Let's start right where the crisis is most visible.
On the hospital floor.
On the floor. The statistics are, frankly, a massive warning signal. Burnout is not solved. Not even close.
What are the numbers?
We're looking at around 45.4% of hospitalists meeting the criteria for actual clinical burnout.
That's almost half the workforce.
It is. But here's the statistic that really floored me. 75.7% score, below the threshold for professional fulfillment.
So even if you're not officially burned out, you're not getting anything out of your job. You're just surviving.
You're just operating in a state of deep professional dissatisfaction. And you can see it physically.
Right, the symptoms are physicalizing. It's not just in your head.
No.
71% report mental fatigue, sure, but then you have 55% reporting physical fatigue and another 55% with emotional fatigue.
This is bodily exhaustion.
It's total exhaustion. And we know what's driving it, and it's not individual weakness. This is a systemic failure.
Okay, so what's the number one cause?
Documentation and charting. 26% of the burden, followed by just general administrative junk.
Paperwork. Always the paperwork. But here's the operational piece that connects it all. Almost half of physicians said they worked without fully staffed teams more than a quarter of the time in 2025.
And that's the reality that pushes this whole conversation beyond just burnout into something much darker.
To
right?
moral injury, yes.
We have to distinguish those two.
We absolutely do. Burnout is the emotional exhaustion, that feeling of being drained. Moral injury, or MI, it's a wound. It's what happens when you're forced to witness or participate in things that violate your core values as a doctor.
So you train to be a hands-on clinician, but the system forces you to be a high-paid data entry clerk. And in doing so, you feel like you're failing your patients. Is that the idea?
That is the essential insight. MI is defined by guilt, shame, a sense of betrayal by the system, and the prevalence is high, somewhere between 30 and 50%.
And the risk factors are all organizational.
All of them. Chronic understaffing, not having the resources you need, like PPE, just impossible workloads, and a lack of leadership support. The problem is absolutely structural.
So if understaffing causes this deep emotional wound, what does the sheer physical grind of shift work do to the body itself?
Now we get to the biology.
This is the nocturnist paradox.
It is. The demand for nocturnists, the doctors who cover nights, is massive. Something like 70% of hospital programs rely on them.
And the pay is incredible.
It's a huge reward. Locum tenens nocturnists can earn up to $509,000 a year. That's about a 15% pay bump over a general hospitalist.
But that money comes with a brutal physiological price tag.
Immense. You are perpetually fighting your own circadian rhythm. The experts in these sources say there should be a hard stop, no more than 4 nights in a row.
To avoid, what, exhaustion and bad decisions?
Catastrophic decisions. And even then, the workload. A general rule of thumb is maybe 8 admissions a night, plus covering the other patients. That's a lot.
And this is where it gets really interesting, because we can now actually measure the damage.
We can quantify it with metabolomics. This isn't just a feeling of stress anymore. This is a lab-verified biological shift happening inside the body.
Okay, so walk us through the chemistry. What is literally changing inside these physicians?
You see this clear signature of chronic stress. First, the obvious one. Cortisol, the main stress hormone, is upregulated. It's high.
No surprise there.
Right. But what is surprising is the massive disruption in steroid hormones. Certain estrogens and androgens like methyltestosterone and estriol are elevated.
And what's being lost in that shuffle? What's going down?
Key regulators are downregulated. We see drops in DHEAS and androstenedione.
For those of us who aren't endocrinologists, what does that mean?
Think of DHES as part of the body's protective system. When it drops, it's a signal that your adrenal system, the thing that manages stress, is just hitting a wall. The body's resilience is compromised.
Also, it's not just that you're tired. The work is fundamentally changing your hormone balance and your ability to bounce back.
And that connects directly to your energy systems. Your mitochondria, the power plants of your cells, are showing signs of strain.
How do we know that?
Alterations in things like L-carnitine suggest the body is struggling to use fat for energy. It's running on less efficient fuel. And on top of that, there's a measurable depletion of noradrenaline.
Which is a key neurotransmitter for focus, for resilience.
Exactly. And that strain, that chemical depletion, it shows up in the brain itself.
The sources said chronic shift work can cause cognitive decline that might not even come back to baseline.
Yeah.
You might not recover.
That's the scary part. It could be permanent damage. The subjective feeling nocturnists talk about, that lack of cognitive clarity,
Brain fog.
it correlates with actual white matter changes in the brain, things linked to small vessel disease.
Which connects directly to long-term neurological risk. Insomnia is a major risk factor for dementia.
A relative risk of 1.13. And sleep disorders in general raise your risk of cognitive decline by about 19%. It's a direct pipeline from the night shift to future neurological problems.
Okay, so let's pull back from the brain to the bigger picture of longevity and mortality.
Right. And there is some good news here. On the whole, physicians tend to live longer and have lower mortality rates than other high-income professionals, lawyers, engineers, you name it.
Probably because of better health literacy, better access to care?
Almost certainly. But that advantage, that physician mortality advantage, is the baseline. When you zoom in,
It's not distributed equally at all?
not even remotely, and this is the truly shocking finding. Look at gender. In the general population, women are about 45% less likely to die than their male counterparts.
The standard female longevity advantage.
That advantage is almost entirely gone among female physicians. It vanishes.
It just disappears.
And not only that, female physicians actually have higher mortality rates from cancers and chronic respiratory diseases compared to male physicians. It's a complete reversal of the norm.
That is just staggering. And it gets worse when you look at race, doesn't it?
It does. The data showed that Black female physicians had the highest mortality rates of any physician group.
Any group.
Any group. The Black to white mortality risk ratio for doctors was 2.13. For Hispanic to white, it was 1.18. And those ratios are higher for physicians than for other high-income professionals.
So the job isn't just stressful. It's actively amplifying these systemic inequities that already exist in society.
That's exactly what the data suggests. It places minority and female physicians at a measurably higher risk.
Given those statistics, I mean.
Yeah,
Planning your finances, planning an exit strategy, it becomes non-negotiable.
absolutely. And on that topic, there's this interesting debate about when to retire. Some studies suggest men who retire early, before 65, actually die sooner.
Probably because of that loss of identity. For physicians, their work is so much of who they are.
It's a huge identity threat, so the planning has to be psychological, not just financial.
What are the practical steps?
You need to decide if you're keeping your medical license. You need to reevaluate all of your insurance, review your old employment contracts, and figure out a plan for your patient's medical records.
Let's talk about those contracts and the regulatory landscape for 2026. Malpractice is a huge source of anxiety.
It's a constant stressor, and we need to talk specifically about tail coverage.
Okay, break that down. Your employer's malpractice insurance isn't enough?
Not after you leave. Their policy is a claims-made policy. It protects the institution while you work there. The moment you walk out the door, you are exposed.
Exposed to lawsuits filed later on for care you delivered while you were an employee.
Years later, potentially. Tail coverage is the insurance policy you have to buy yourself to cover that gap, and it is incredibly expensive.
How expensive are we talking?
The sources cited cost like $13,000 after just 11 months of employment,
Wow.
or up to $30,000 after just 3 years. This is a massive cost you have to budget for or negotiate for the employer to cover when you leave a job.
Okay, moving to the job market itself. The 2025 data had some good news around it. Primary care compensation was up.
Yeah, overall compensation gains were pretty healthy. Primary care saw a median increase of 5.8%, which is strong.
But there was an exception.
The hospitalist specialty, and this gets right back to what we said about burnout. Hospitalist pay went up, but only moderately, about 2.5%.
Okay.
But their productivity, the amount of work they did, grew way faster. at 5.8%.
Wait, so they're working harder, but their pay isn't keeping pace. Let's translate that. Productivity is measured in WRDUs, right?
Correct. The work relative value unit. It's how hospitals measure physician output. And because productivity grew faster than pay, the compensation per WRVU ratio actually decreased by 1%.
So in real terms, hospitalists worked almost 6% harder just to get paid proportionally 1% less for their effort.
That's it. It's the definition of a hamster wheel. It confirms the system is demanding more for less.
So what are the alternatives?
Well, locum tenens is still a very flexible, high-paying option. And for those looking to get away from the bedside entirely, there are non-clinical roles.
Like what?
Entry-level utilization review, for example. The average salary there is between $200,000 and $250,000, with some reports up to $320,000. So there are viable pivots.
Okay, lastly, we have to cover these massive regulatory changes coming for student loans.
This is critical. Major plans are ending, and new rules for public service loan forgiveness, or PSLF, are coming in.
What's changing with PSLF?
Effective July 1st, 2026, the Department of Education can actually disqualify an employer from being PSLF eligible if they're found to have a substantial illegal purpose.
So if your nonprofit hospital system gets hit with a major fraud judgment.
Your employment there might suddenly not count toward forgiveness. It's a new risk to track.
And what's this about the old payment plans going away?
This is the big deadline, the IDR plan sunset. For anyone with loans from before July 2026, the old popular plans like PayYE and ICR will be phased out by July 1st, 2028.
And everyone will be moved to what? The new RAP plan.
The new Repayment Assistance Plan, or RAP, will be the main option. Payments are between 1% and 10% of your income. You have to figure out now how that transition will affect your monthly budget.
And there's a huge tax bomb on the horizon.
A financial cliff. Unless Congress acts, that temporary rulemaking, most non-PSLF forgiven debt non-taxable, it expires.
Wow.
Any debt forgiven on or after January 1st, 2026 will likely become fully taxable income again.
For a physician with a few $100,000 forgiven, that's an enormous immediate tax bill.
Potentially a six-figure tax bill overnight. You have to be talking to a tax professional about this now.
So to recap, we've got the severe emotional toll of moral injury, the surprising metabolic and neurological damage from circadian disruption, and this urgent need for financial and legal planning in a changing landscape.
The sources really paint a clear picture. The profession offers a longevity advantage, yes, but it is simultaneously harming the bodies and minds of its members, and that harm is measurably worse for women and people of color.
Which brings us to our final thought for you to consider. If organizational failures and the grind of shift work are causing measurable physical harm, literally changing metabolites and driving up mortality rates, what practical steps, beyond just telling doctors to be more resilient, must organizations implement right now to close that shocking mortality gap for female and minority physicians and ensure the profession isn't structurally destroying the very people it relies on?